Yeah, I think the REBEL trial is a very interesting one. Is the study comparing in second line of patients with non-ischemic histology and ischemic histology, both histologies, docetaxel placebo or docetaxel ramucirumab. This trial showed that the combination of docetaxel and ramucirumab improved overall survival, and this is really important because patients with lung cancer need a number of treatment strategies. So I think at present we have in second line the possibility to prescribe immunotherapy, an anti-PD-1 compound or an anti-angiogenic compound plus docetaxel.
If using the combination of docetaxel plus ramucirumab or nintedanib or immunotherapy, I think that is the most relevant questions for the treatment of advanced non-small cell lung cancer in second line. This is because the story of the PD-L1 is still unclear. We don't have a real cutoff, and we have trials in which it is clear that the benefit of immunotherapy is independent by the PD-L1 expression. However, I think that if we have a patient without a strong expression of PD-L1, it's quite difficult to achieve a good response with immunotherapy. So in patients with PD-L1 negative or in patients with low expression of PD-L1, I think that we have carefully to think to the possibility of using docetaxel together with anti-angiogenics. This because if the patients progress also during the second-line therapy with immunotherapy, it is possible that you are not able to treat the patients with docetaxel and anti-angiogenics anymore. So in my opinion, we have to think to a strategy of treatment of these patients. So in patients with low expression of PD-L1, you have to try to use all the components, all the strategies, all the chemotherapies that you have now for this kind of patients. So in my clinical scenario, maybe I would use before chemotherapy plus or minus anti-angiogenics in this kind of patients. Then there are some data suggesting that angiogenics works better in patients with achieving a bad outcome in the first-line chemotherapy and having a progression before 9 months. And they are subgroup analysis, but the advantage in these patients of the combination chemotherapy is huge. And so I think that we can think also to this possibility.
Well, ramucirumab is approved in squamous and non-squamous lung cancer alike. Nowadays, of course, it got approved just as immunotherapy was approved for lung cancer. So my suspicion is if someone's getting chemotherapy for lung cancer first line, their second line choices would include immunotherapy or ramucirumab plus docetaxel. It's not used alone. My sense is many people might go to the immunotherapy first, though I would contend perhaps you could look at a biomarker, and if their patient's PD-L1 totally negative, you might want to go to the chemotherapy ramucirumab first, and the results are in combination with docetaxel. So it will be used there in a setting where you would use docetaxel. If you're not using chemotherapy as your second-line therapy in lung cancer and you use immunotherapy, then you're saving your chemotherapy for the third line. Of course, many people like to use pemetrexed as their second-line therapy. So the issue is, you'd have to use this drug with docetaxel. But it's a good drug, it's a good combination, and it helps patients with a positive survival result, FDA approved.
The best candidates for anti-angiogenic treatment, in my view, we have now in second-line treatment, we have the immunotherapy and we have these agents. And to properly select patients is difficult, but we have to keep in mind that with the immunotherapy, we see impressive results. We see for the first time long-term survival, so that's really, really impressive. But on the other hand, we have to take into account that that's the minority of patients. So the majority of patients we lose before that. And certainly in the immunotherapy, we know that when you look at the trials, that you lose about 30% of patients already in the screening period. And these are the patients who are having the rapid progression or and even shortly after chemotherapy or even during chemotherapy. And I think these are the patients in whom we probably better start with the chemotherapy in combination with the anti-angiogenic agent at this point of time. And we don't know what's coming up, but for now we know that in the first, looking at the first month after the start, also in the immunotherapy trial, comparing it to docetaxel, we saw that in the first months of treatment, we lose more patients on immunotherapy than on the docetaxel. So I think we have to do a proper patient selection, and for now we know that rapid progressor patients are certainly one of these patients which we should treat. The other thing is how to introduce this PD-L1 staining and select patients based on that. And also, in that point, my personal opinion is that PD-L1 negative patients should be treated with other agents than immunotherapy at this point, and the scientific knowledge we have now.